We're going to show you Mako partial knee replacement 3.0 planar workflow. The difference between the burr-only workflow and the planar workflow has to do with the cutting tools that we'll be utilizing on the robotic arm. As you can see on the robotic arm right now, I have a saw that's mounted, and that's for the planar cuts that will be done on the implants, including the femur and the tibia. So the proximal tibial surface is flat, and so with the planar workflow, we're able to cut that proximal tibial surface with the saw. On the femoral side, the posterior condylar surface is also flat, and so we're going to be cutting that with the saw as well. The burr will cut the remainder of the resection. So on the tibia, it'll cut the wall adjacent to the tibial eminence, and then the remainder of the articular surface, as well as the post holes, will be prepared by the burr. So the planar workflow includes both the saw and the burr to effectively do bone preparation. I'm now going to bring the saw towards the knee, and I'm going to take my green probe, and with the green probe, I'm going to validate my tibial array to make sure it hasn't moved. And you can hear and see that that is passed. I'm then going to take the dimple on the top and on the bottom of this saw blade. I'm going to put the blunt probe in there, and again, that's passed. So the robotic arm is now able to be used to effectively perform these bone resections. I'll move the arm towards the knee, and you can see as I do that, up on the work screen, you can see that yellow boundaries have appeared. That tells me that the saw is close enough to the plane that if I depress the trigger on the mixed handpiece, that it'll automatically align. Prior to doing this for soft tissue protection, there's a couple of things that you want to make sure that you're visually confirming. One is, you can see this self-retaining retractor that I utilize. This is the workhorse retractor that I place in medial-laterally. On the most medial side, I put it in the intact meniscus, and I'll take out the meniscus later. That helps push the medial collateral ligament medially and out of the way. And likewise, the lateral side of this spiked retractor allows the patellar tendon to be pushed out of the way. For further protection, I'll take a Homan retractor, or you can use a Z retractor if you like, and I'll place this inside the joint, just like that, at the level of the MCL at the joint line, where the saw is going to be resecting bone. I can simply hold this with one hand, and then as I bring my saw into the field, again until my yellow boundaries pop up. And once the yellow boundaries are popped up, when I pull the trigger, the motorized alignment feature is going to bring my saw blade onto plane. Like that. Now you can see, I can release my trigger now, and I'm on plane. The boundaries are green, and that tells me that this saw is on plane and ready to cut. So simply pull the trigger. Utilizing the planar workflow, we're able to make this saw cut within the haptic boundaries defined by those lines that you're seeing on the workstation, and with this additional soft tissue protector, this Homan retractor that I have at the joint line. I've just completed my planar resection on the tibia. I'm going to remove my retractor. Before we move on to the femur, I think it's important to note that at this stage you do not want to use an osteotome to lever out this piece of bone. We still need to make the resection with the burr adjacent to the tibial eminence so that the bone is released atraumatically. Now we're going to move on to the femur. What I'm going to do firstly is I'm going to validate my femoral array. And I do that by putting my green probe into the checkpoint, and you can hear that that's been validated. Now you can see my MPS is showing that the flexion angle is only 109 degrees. And in that degree of flexion, you might run into the tibia as you try to cut the posterior condylar surface of the femur. So I'm going to actually put some more flexion on this knee and bring it up just beyond 115 degrees. We got about 118 degrees right there, and that should be adequate clearance. I'm now going to put in my soft tissue retractor to protect my MCL, and I'm going to hold it just gently with my opposite hand, my left hand, like that. I'm going to pull my saw in until I see the boundary appear, which is yellow, and now I'm going to depress my trigger until it turns green, telling me that the saw is on plane. So this motorized alignment feature aligns the saw to the cut plane, as you can see on the work screen. Now I simply have to depress the trigger, it'll activate the saw, and I'll make my posterior condylar cut on the femur. And that completes that cut. So now that I've completed my posterior condylar cut utilizing the planar workflow, I can remove that segment of bone because it's completely loose. So I can give myself a little bit of backhand here and reach in with a hemostat and remove that fragment of bone. I've now completed my planar cuts and I'm going to switch to the burr. So I'm going to rotate the mix handle facing upwards so that the mix doesn't fall, or the saw doesn't fall. I take out the saw piece. So I've removed the saw and now I'm ready to place the burr. You'll notice that the locking mechanism here shows a red line in the unlocked position. So when I put the burr into the mix handpiece and I see the red line, I know that that burr is still unlocked. I then twist it, the red line goes away, and the burr is locked onto the mix handpiece. So I've assembled my burr, and now I'm going to place on the irrigation tubing. It's important to note that there's an arrow pointing away from the mix handpiece, and the arrow is pointing to the tip of the burr. And that denotes which direction the irrigant is going to go. So it needs to be arrow facing the tip of the burr because that's where the irrigation is going to go. Now I'm going to move the handpiece towards the knee, and I'm going to take my X-array, and I'm going to dock the burr into the dimple on the X-array, and I'm going to face the VisiDisc towards the camera to validate my cutting tool. And you can hear and see that validation. At this stage of the game, I'm ready to perform my burr resection. So I'm going to bring this into the haptic just by coming in like this. Audibly, you hear that I'm now in place. Now, once I'm in the haptic, I'm just going to press my trigger. That activates the burr, and I'm going to start resecting bone. So I'm going to start at the bottom, and I'm going to find the floor of the resection, which is white. So once the green is out of the way, I can then stay on the floor. I think another nice feature here to think about is the different ergonomic positions that you can place this handle in. And everybody will have a different comfort position for their handle, but I've just deployed this handle 90 degrees to the side. That'll let me have a little bit of a different feel as I'm utilizing the tool. You can see I'm just working from the white patch into the green. I'm going to change my angle because the burr works in my hands much more effectively if I'm pushing it at a little bit of an angle to the articular surface. And you can see I'm just kind of polishing away the bone as I'm moving from posterior to anterior. You can see sometimes I'll sweep side to side, and sometimes I'll push more into it. Now as we move to the front of the resection, it's important to know what your soft tissues are doing, and sometimes you'll need a Hohmann retractor in the notch to sublux the patella a little bit. So I'll take that retractor, and I can hold this myself. As I put this in, I'm just going to hold that retractor with my thumb. That allows me to sublux the patella out of the way and complete that most lateral aspect of the anterior portion of our implant without worrying about hitting soft tissues. You can see this high torque burr removes bone very quickly. I'm actually applying very little force to it and just gently pushing it into the bone to allow the cutting tool to work. Good. That concludes the articular surface on the femur. So we've now completed our articular resection and we're ready to do our post holes. So you can see the virtual burr on the screen. I'm bringing the arm close to where my post hole is going to be, and then I'm going to depress the trigger, and depression of the trigger aligns the burr to the post hole. I'm now going to maneuver my burr so that I have almost a perfect circle or a bullseye. I'm going to pull the trigger and simply push in. I think one of the important teaching points, let's go posterior, Mike, when we're doing this is that you want to bring the burr speed up to full before you press it onto the bone. You don't want to start the burr on the bone because you want the full effective cutting speed of the burr to be activated before you touch the bone. So again, I'm going to pull the trigger. It aligns itself. I give myself a bullseye. I release the trigger. I pull the trigger, start the burr, and simply push in. And we're done. I'm now going to realign my handle because I'm more comfortable doing the keel with the handle in the vertical position. And again, I'm going to align myself to my keel by pulling the trigger and holding it. And then resecting the bone from anterior to the anterior post hole, through between the post holes, and then posterior. And you can see I'm changing my hand angle to get posterior to the posterior post hole. So our femoral resections are now complete. We're going to now move on to the tibia, and because we're switching bones, we'll need to again confirm that our tibial array hasn't moved. And in fact, it hasn't. Once again, I'll visually inspect my retractors and make sure that I have appropriate soft tissue protection so I'm comfortable as a surgeon. So I'm bringing the burr in to perform the tibial eminence resection. I bring it in by hand until I see the virtual burr on the screen. Then I'm going to pull the trigger and hold it to align the cutting tool to the cut that we're planning to make. It's important to visually inspect your soft tissues. In this case, we have a Gelpie that's holding our soft tissues out of the way. And you also want to make sure that in your patient's particular anatomy, that there's adequate space to protect the femur. So if the femur is sagging and close to the tibia, you have to be careful when you're resecting the posterior half of this tibial bone to make sure that you don't do any damage to the femur. I now pull the trigger and I begin my resection. And the resection really involves a small portion of the floor, and I'm going to realign my arm a little bit, but more of the wall where you're lifting up from below and polishing out that bone. I'll often stop halfway, as it's sometimes appropriate to remove this anterior half of this tibial resection. In testing this with my thumb, it's still a little tight and I would like to take it out in a more atraumatic fashion. So I'm actually going to change the position of the leg so I can achieve resection towards the posterior of the knee more comfortably. So you can see I'm externally rotating the tibia a little bit, and that allows me a little bit more of a straight shot. With this leg that was previously neutrally rotated, I felt like I was reaching around a little bit, and ergonomically I think this will allow me to get my resection towards the back of the knee more comfortably. So I'll continue with my resection, and you can see, if you look closely at this stage of the game, the shaft of my burr is starting to abut the front of the resection. So it's very difficult for me to go beyond this point without removing this bone. So I've gone about as far as I can go, an anterior 2/3 or so. Now I'm going to remove that bone so that I can get the shaft of the burr past it. And now that this bone is gone, the thicker part of the shaft of this burr will be able to be placed in towards the back of the knee to complete the resection. And again, sometimes you'll get some deflection from the meniscus in the back of the knee. Very commonly in arthritic patients, you don't have much meniscus back there, but we had a little bit here in this cadaveric specimen. And now our resection is complete. So the additional benefit of bringing your flexion beyond 115 degrees and externally rotating the knee is that your position for your post holes will be easier to achieve. So we're going to move on to post holes next. And again, I'm going to pull the trigger and hold it. I can perform the resection at this angle, but I'm going to push the handle such that I'm a little bit more vertical and more perpendicular to the articular surface. I'm going to pull the trigger and simply push in. That's the anterior post resection. And again, I'm going to do the same thing with the posterior post. We're aligned and we're complete.